Thanks so much, everyone, for having me, and I really do appreciate the opportunity to be here. It's just always wonderful to be back in this meeting and be back in Napa. So I do realize that aortic stenosis is being presented in a session on preventive cardiology, and so hopefully my topic and my presentation won't be too much of a departure from the themes of prevention. But there are some interesting things that when we think about a top 10 or 10 commandments of aortic stenosis that I've been kind of putting my thoughts together that hopefully will provide some food for thought for all of you. So when we look at aortic stenosis, it's really clear that despite all of our advances, that there are still large populations of patients with aortic stenosis who still are untreated. And so these are data from our hospital, and you can see here in yellow are all patients with severe AS by year, and then in orange are patients who have made it to a cardiology visit, and then green are the patients who actually ended up having AVR. And when you look at this, about 60% of patients with aortic stenosis that's severe still do not get aortic valve replacement. And I think we're a pretty aggressive center, and so these are data in our center, which is a tertiary center, so you can imagine what that might be out in the community, and that most patients don't get therapy. And you know, one of the issues is that we know that AVR, whether it's surgery or TAVR, is life-saving, and so that lack of therapy going untreated is despite the recognition that we all know that AVR saves lives. And that's the case even among patients who are inoperable or high risk. If you look at the partner study, the number needed to treat was only 5 to save a life. And so when we look at these data, you know, we might think, well, why do so many patients still go untreated? Well, one of the issues, and when we're thinking about aortic stenosis, is this persistent risk of mortality. And so if you look at this at 1 year, despite what we do, about a third of patients still die. And it's probably even higher and among an older patient or has somebody who has other morbidities. So when you think about this, you think about this persistent risk of mortality, and you start to think about, well, what is the futility in terms of what we do? And these are some of the markers that we look at in terms of futility. We look for lung disease, dialysis, severe mobility, cirrhosis, malignancy, and dementia. And we look at these things and think to ourselves, well, do any of these patients have these markers that would essentially create futility in terms of what we do? But when I was asked to think about, well, let's think about aortic stenosis in a new way, what do we do when we have these markers of futility, but we now have a procedure that's become incredibly safe? In other words, TAVR has become very much like PCI. And when we look at each of these different patient subsets, it's still more likely to help than not. And if anything, it may help a patient in terms of their heart failure. And these discussions become really, really hard because when we talk about futility, the relevance is really more relevant when there's uncertain effectiveness or when something has some relatively unclear safety profile or is just simply unsafe. And so when we're thinking about aortic stenosis, these discussions, I think, are much harder now than they've ever been. You know, the TAVR data have actually made those discussions much harder because it's become a relatively easy procedure to do. It's relatively safe. So that's one of my new commandments with aortic stenosis. We have to think about those the discussions when we approach these patients in different ways now because it is much easier to do. And as an example of that, we know that patients with aortic stenosis commonly present with paradoxical low flow, low gradient. About a third of patients will have these findings, and these patients actually probably maybe becoming more common in our practice. And the challenge with these is it's almost like another marker of futility, and it's because we know that TAVR is very effective in these patients. It does improve survival, but TAVR and AVR for patients with low flow, low gradient doesn't really impact the flow, and there's still a persistent risk of mortality. Their mortality in hospital is twice that of a patient with classic aortic stenosis, and the long-term mortality is also twice that. And so there's this persistent risk of mortality among these patients. And when you look at these, it can be related to so many different entities. It can be related to diastolic dysfunction, LVH, AFib. We look for all of these different causes that can contribute to this low flow state and persistent symptoms, and we have to examine them much more in detail, unlike ever before. And that's again because we often get asked these questions, well, why don't you just put a valve in? Well, the problem is that it doesn't always help in terms of symptoms, and there can be this unfortunate patient dissatisfaction with how they feel after what we've done, even though overall we probably have helped them live longer. So I'll share with you a couple things that we've been doing in our practice, and what we do is we now take these patients with low flow, low gradient, and if they have these findings, we bring them all to the cath lab. It's a requirement that they get a hemodynamic study. And we also now give them nipride. And so here's an example. So on the left-hand side, this is a patient with low flow, low gradient 32, valve area of 0.9, and we give nipride to help lower that high blood pressure. And with that, the gradient's 45 and the valve area is 0.9. So it's kind of unmasking severe aortic stenosis. And the interesting thing is that you can also have it go the other way. About a third of the time, the aortic valve area actually increases and goes outside the severe range and becomes moderate. And so we actually do this as a challenge to make sure that the patients have anatomically severe aortic stenosis, much like you do dobutamine for low EF. We do nipride for patients with normal EF and low flow, low gradient. And then the final thing we do is we've actually done a lot of integration with the cardiac MRI. Many of these patients have changes in the myocardial architecture that you cannot see with echo. And so you can see here about half the patients here would have normal, about a quarter have extracellular expansion, and then a quarter have replacement fibrosis. And you might think, well, what does this mean? Well, in this study, you actually have a 5-fold increase risk in the long-term risk of mortality if you have extracellular expansion, but you also have a 7-fold increase if it's replacement fibrosis, almost 10-fold actually. And so this is again counseling those patients because these patients would be at risk for diastolic heart failure, persistent symptoms, as well as increased risk of mortality. So those are a couple of things that we're doing in our practice. So in my commandments here, and then the final thing is we found about 1 in 7 will have actually amyloidosis on cardiac MRI, so an important thing to pick up. So in my commandments here, I still think that most patients, despite the advances of TAVR, still go untreated. And in a discussion about TAVR and futility has actually become harder because the procedure is relatively safe and easy. And we as a group will have to decide, well, how do we decide what is futile anymore? We have changed a lot of our focus to educate the patients on the persistent risk of symptoms as well as mortality after the procedure that can be due to a variety of things. And for those low flow, low gradients, think about the etiologies, think about nipride challenge, and think about cardiac MRI. So that's it. Thank you very much.